Can you hear us?
Can you hear me?
Yes.
Little bit of a, well, I'll keep talking. Okay, it's working. How about that? It's like magic. Magical powers. We have magical powers. And questions. Good morning, Dr. Rosensweet.
Good morning, Carolyn Shapiro.
I'm glad you remember my name. God knows I'm good enough. little bit of morning humor. Whew, breathe. Okay. We have some nice questions this morning, and thank you for approving them. I like them, and I know I'm going to like the answers, so here we go. Okie dokie. Mr. Bijou and Emily say hello to you and to everyone as well, you know. Okay, Dr. Rosensweet says that he can tell if a woman is on hormones. This is a 70-year-old woman, and she's asking, how can he tell without testing?
If you were as immersed in hormones as I have been for the last 25 years, and you've seen the number of women that I have who are on consistent hormone treatment into their 60s and 70s, for example, you can start seeing that women who are on hormones, their skin looks a lot better, their hair looks pretty good, their vital energy is pretty good, they're cognitively really sharp, plus or minus. It's not like we're not aging, but the older you get and the longer women have been on hormones, like you're starting to look at women in their 70s and 80s and their skin looks really good and their hair looks really good and they're really clear and vibrant.
Chances are
they're on hormones.
Yes.
Remember, hormones were super popular in 2002 before the Women's Health Initiative. 40% of American women were on hormones who were in menopause.
That is right.
And so, you know, it's not a big deal that I can tell. Anyone could tell if they just start if you just start asking yourself when you're walking down the street and you see an older woman who looks especially good, skin-wise, hair-wise, vibrancy-wise, high likelihood she's been on hormones.
And you can also tell when someone is not.
Yes, you can.
You know?
And skin is one of the major testimonials for that. And sarcopenia, I mean, I lived in Florida for a long time, and on the beaches, for one thing, you don't see a tremendous number of older folks on the beaches. And even though they're in Florida, and when they're walking the beaches, you'll see those thin thighs, much thinner than when they were younger. That means they've got muscle loss, and that's highly significant. Or if you see the triceps area and there's a lot of flab there, they've lost triceps muscle. And that's sarcopenia. And this is, again, as I've said many times, one of the most important things that we do is we replenish the androgens, testosterone and DHEA, get them up to good levels, decent levels.
Well, I'm going to just say my own testament, 3 years in, the woman you're looking at right now is not the woman that you met back in the day, you know? And I attribute this to hormones and definitely to you and menopause method. And I have such gratitude. Oh, do I have gratitude? Yes. Let us welcome in Shirley and Kathy and Paula and JJ. Good morning, everybody. All right, on to question number 2. And thank you very much, because I know that a lot of women, and we've discussed this, in their 70s say, my doctor won't test me. I don't understand. And I kind of figured this out early on, that if I were to be tested, I would come to find that I was making 0 hormones. So, you know, I knew this. 17 years in. For
Yeah,
me,
there's no need to test a woman who's a year out from her last period, well into her 70s and 80s. There's still a little ovarian estrogen and testosterone coming from testosterone conversion, especially if a woman's overweight, but the levels are super low. So we never, ever test a woman who's a year out in the beginning. We always test them once we put them on the hormones. And
right.
they say, hey, I feel a lot better. Then we test them to make sure their levels are good. But 100%, it's not like it's 99%. You're 70 years old, you're many years out, your hormone levels are super low. No need to test you. You may have symptoms, you may not, but your hormone levels are super low. Enough to put your bones and your arteries and your brain and your bladder and your vagina and your muscles at risk for losses that you do not want to meet up with in your 80s, in your 90s. You're not going to like it. It's the principal reason why women wind up in assisted living facilities and nursing homes. The main reason is they lose their muscles, the arteries, etc., the vagina, the bladder, adult diapers. Hormone replenishing is a big deal, and your life will matter as much to you when you're 80 years old and 90 years old as it does now. It's not going to be different. You're going to care about how good you feel.
You just stole my line. I was just going to say that because it is something that I'm well aware of, and I think of it all the time, and I now say it all the time. It comes right out of my mouth. Your life is going to matter to you just as much 10 years from now as it does to you today. All right. Okay, this is an interesting question to me because I didn't even think of this. Can you please explain how it is that estriol taken alone can cause or contribute to apoptosis?
Oh, yeah.
Oh, yeah.
Well, I want to back us up some.
Okay.
Into a young woman's menstrual cycle.
Okay.
And it was just staggering to me when I first learned that every single menstrual cycle, a young woman is preparing for possible pregnancy.
Mm-hmm.
In several ways. The hormonal outputs affect the thickness of the endometrium, making it a very rich lining of the uterus to receive a possible fertilized egg so that it can implant. Major changes take place in the uterine lining over the course of a month. But other changes that prepare for pregnancy occur as well, including once a month, a young woman is preparing for breastfeeding should she get fertilized ovum. You'd wonder, why in the world would it start that early during every menstrual cycle? Well, I don't know the answer to that, but I can tell you it does. Once a month, women's breasts also prepare for the possibility of breastfeeding. Now, if there is no pregnancy, they unprepare, and they do this every cycle. I don't know if that's a word or not.
Unprepare works. We get it.
Okay. So in the beginning of a cycle, as estrogen levels increase, breast glandular cells actually proliferate. You get more of them. Young women can feel this very often as her breasts get fuller as the cycle progresses. She's actually adding breast glandular cells in preparation for possible breastfeeding ultimately. However, if she doesn't get pregnant, these proliferated cells disappear. And a woman can tell that by the time, somewhere around the time of her cycle, her breasts are less full. You've had actual disappearance of those new breast glandular cells. And this cycle repeats every single cycle. If she gets pregnant, the initial proliferation and additional breast glandular cells keep on proliferating until ultimately at the when the baby's born, she's ready to breastfeed and produce milk, and quite a lot of it. No wonder you have to produce. No wonder you have to proliferate cells beginning pretty early on to prepare for breastfeeding. Well, the proliferation phase, where you get cell division, otherwise known as mitosis, and you get additional cells, that is under the influence of an estrogen, special estrogen receptor site known as estrogen receptor site alpha. And then if you don't get pregnant, the deproliferation, the disappearance of these cells, is under the influence of an estrogen receptor site beta. Alpha proliferation, beta deproliferation. And alpha, the prime stimulant of estrogen receptor site alpha, is estradiol, which is produced by the female ovary. It's the most potent estrogen produced by the female ovary. And estrogen receptor site beta is under the prime influence of another estrogen that comes out of the ovary called estriol. And in a young, healthy woman, there is more estriol than there is estradiol, and a hormone that I haven't mentioned, estrone.
Right.
There's somewhere between 1.1 and 1.3 times as much estriol in a young woman as there is the sum of estrone and estradiol.
That's wild.
So to get back to the original question, that deproliferation that's under the influence of estrogen receptor site beta, probably more information than anyone could ever need. And estrogen receptor site beta is under the influence of estriol.
Right.
That deproliferation, the disappearance of those cells, is given this poetic name to me called apoptosis.
Pop.
I think that's pretty fun and funny, but I don't know if an actual pop takes place in these cells, but they do deproliferate, they do disappear.
Well, and otherwise they commit cell suicide.
Well, I don't like that terminology.
No, I know.
It implies that there's, I know it's used all the time, Carolyn.
Sorry, I will.
No, it's used all the time. It's a very common usage. But in a healthy young woman, there ain't no suicide going on there. It's a mixing of terminology.
Okay.
And, you know, you hope there's cell suicide in the world of cancer.
Yes, exactly.
Apoptosis also can occur when the immune system does a great job with cancer cells that develop. So I know that has bled commonly over into cell suicide with what happens monthly. But
well, this is why we have you to point it out.
Yeah.
Yeah. So beautifully.
Now, in our book, Happy Healthy Hormones, that you have posted on the website. I
do, and yeah, I'm all backwards here. This is weird.
Yes, isn't it?
Yes, it is.
I have references to the medical literature on estriol and its influence of estrogen receptor site beta. It's a very important phenomena in treating women in menopause, because what do we want to do in menopause? We don't want cell proliferation in menopause. So we emphasize the usage of estriol, which is the deproliferator. It's the principal receptor stimulant of estrogen receptor site beta. In fact, the initial formulation that we provide of estrogens has 2 estrogens in it. It's got estradiol, and it's got 4 times as much estriol as it's got estradiol. And why do we do that? Because we're trying to copy nature. So when we look on a 24-hour urine hormone test, we see a heck of a lot more estriol than we see estradiol in there, because we love estrogen receptor site beta, i.e. deproliferation. We're not interested in breast glandular cell proliferation in a menopausal woman. And, you know, mitosis in a 20-year-old is different than mitosis in a 60-year-old. Mitosis is a vulnerable place. It's a vulnerable moment. because it's a place where mutation can take place. And, I know I'm going way too deep into the quicksand here around details here, but we pay attention to these kind of details because we're not real interested in a lot of mitosis in
Right.
elderly folks.
Yes.
Because if there's a mutation, well, under very healthy and robust circumstances, our immune system will identify that mutation, that cell that mutated, and go, hey, not here, folks. We're going to transfer you to a different reality system called we're going to pop you out of this planet. Yeah.
I'm already there. Anybody wants to join me?
You think? You think
no,
you're?
I don't think.
You think you're co-inhabiting multiple reality systems, Carolyn Shapiro?
No, I think you can answer that for me pretty well.
So anyway, not to stray from the point. Far be it from us to stray from the question.
So sorry, ladies. It's that kind of morning. A lot of laughter. You gotta laugh, and you gotta love.
Perhaps we should move on to the next.
We're going to. I'm looking at my questions as we speak. This is a long question. It's a good question. And question just came up. How can Dr. R tell when women in their 70s taking hormones? He says he can pick the women out. What does he see? We did answer that question at the beginning of the video. So I'm really happy that you wrote that. Thank you and welcome, Maria. I was given a very low dose, not me, but the questioner. I was given a very low dose of testosterone to try. I believe it's 0.25 milligrams. I'm not sure. She said 2.5 milligrams. From a 5 milligram per ml bottle. Severe acne and aggression. Dose is really small. One pimple is becoming a cyst already. And I have 2 others, meaning pimples, that are doing this cyst thing. I felt great and even went out to lunch with my friend, which I haven't done in forever. But I do not want cystic acne on my face at 46. I'm using injections right now and help. Thank you.
Well, I think the fabulous news is you took some testosterone and you felt great.
Yes.
Yeah, because testosterone depletes right along with all the rest of the hormones. And testosterone is not a male hormone. It is a human hormone, and women need their testosterone profoundly and forever. Now, you can say that was, quote, low dose, but it was not a low dose. It was an excessive dose. It was an excessive dose. And how do I know? Because you got symptoms of excessive testosterone.
Right.
Cystic acne. Yeah, adolescents, man, they got that testosterone coming on like gangbusters. And they get acne. And because they're such robust levels, and you gave yourself an overdose of testosterone. Now, I am absolutely not a fan of testosterone injections for women. For one thing, it's so non-physiologic. What are you doing them once a week or twice a week? You're giving yourself a burst and then a decline. It's just not the way to do it, especially when testosterone works so beautifully when you apply it topically, which is the only way you should take it, because we do not take testosterone by mouth. It can injure the liver. But testosterone works beautifully. Like, oh, what's this? This is a bottle of my testosterone in our organic oils formulation. Yes. And every single woman that we treat in menopause winds up with one of these bottles of testosterone or testosterone mixed with DHEA. So, yeah, daily application is so much more physiologic. And so much more copies nature, and it absorbs gorgeously. So you got a little bit of, the good news is you realize that your body likes testosterone.
Yes.
As does everyone's. And you just were on an overdose. So find someone who can prescribe you topical testosterone and take it daily, and you'll find your own dose. And if you still get acne, you're still on a little bit too much. Oh my goodness, my niece.
I just saw that. Hi, Uncle David.
Hi, Sarah.
It's Old Home Week here.
So good to see you.
Aww. Man, we got some questions coming up. And welcome to your dear, dear niece. And welcome to Yowza, Regina, and Sarah, and JJ. I don't get your question here. Tanya. Okay. Let me interject really quickly this. Oils, took them testosterone, and I didn't like it because I was in overdose. I was very anxious. And I, in my mind, thought, well, I just can't take testosterone. It doesn't agree with me. Never say never. The milligrams were decreased. I was able to take 3 teeny drops at the beginning, like for the size of an ant, and it worked. No, I'm not kidding. Like teeny. I was so scared. I am now a year into taking testosterone. I do feel a lot better. The agility is there. The clarity is there. I go out to lunch with people, and I'm on the same page. I'm not a doctor of 50 years or dealing with women in menopause for 25. However, I am the woman taking the testosterone, and I just feel that we are so fortunate to be able to experiment and go low and go slow and, yes, make it work. I agree with you. The testosterone worked. Yay. A little bit too high of a dose. Not yay. Low, slow. Yes? No? Yeah?
Yeah, you get the dose right.
Right. Oh, that. Yeah, exactly. Okie dokie. Next question. I suffer from severe PMDD, life crippling. I cannot have hormones or my symptoms will return. What can I do? If I take hormones, won't it bring all the severe PMDD symptoms back?
PMDD, what is it? It's distress disorder. These stress disorders related to hormones are either related to imbalance or insufficiency or both. So the trick is to identify what exactly is going on. And unfortunately, there's not enough information conveyed in that question. But if it's related to hormones, if the distress disorder is related to hormones, which very commonly it is, premenstrual distress disorder, we want to know, well, if it's very commonly related to hormones, what is the hormone configuration that's causing the problem? Because all kinds of insufficiencies and imbalances can take place. In a young woman, one of the more common things that happens that causes a great deal of duress, or small, medium, or large, is an insufficiency of progesterone to balance the estrogen.
Yes.
Estrogen is very stimulatory. Stimulates the uterus, stimulates the breasts. Progesterone is very calming. Calms down and balances the stimulatory effects of estrogens. And a very common event that takes place in a woman who's still menstruating is the progesterone is declining more dramatically than the estrogen is. I say declining because, as I said many times, a woman's hormone levels peak output occurs at the age of 20, plus or minus 2 years. And then from that moment on, it starts declining. And then there's this cliff falling off at menopause, and it continues to decline from that point on as well. So progesterone can decline earlier and more profoundly than estrogen. That means the stimulatory effects of estrogen are prevailing. Even though there's less estrogen at the age of 30 than there was at the age of 20, the balance from progesterone is not there. And so you can get mood issues, sometimes really wild and dramatic, depression, anxiety, really upset. Sometimes you can get overstimulation of that uterus and get cramps as never before. So to shoot from the hip, which I recommend that some women, if they don't have access to physicians and prescribers, get some over-the-counter progesterone, and during the second half of your cycle, see if that doesn't quiet down some of the distress disorder. Now, over-the-counter progesterone is not as strong as what I like and what I prescribe. For example, it's 1.8% or maybe 2%, and will commonly begin with at least a 3%. So you want to be sure you get enough dosage. But bottom line is, when we take a very, very careful and focused medical history, we're going to listen to the symptoms or lack of them in great detail. And sometimes that'll be the clue to a woman in the perimenopause of what's going on, or certainly to a woman in the menopause. And so it might suggest something as simple as add some progesterone. So without knowing the details of your situation, significant distress is definitely possible. You know it.
Distress? D-I-S-S-T? Distress?
Distress, yeah. Distress. Something's very, very stressful.
Got it.
And then can it be ameliorated by hormones? Very often. Something's going wrong there. So we want to figure out what it is. And often the symptoms will reveal. And then the common stuff is common. So in a 30-year-old woman or a 35-year-old woman who's starting and getting more and more distress around the time of her periods, she's usually not having adequate progesterone to balance her estrogen. So get some over-the-counter progesterone and check it out. It will not hurt you. If it hurts you, if you get worse, well, of course, stop it.
Yeah, well, yeah.
Then you'll need a professional to help you sort it out.
And again, as we say so often, and I am just blown away always, and we've been doing these interviews a long time, with your knowledge and the way that you explain this out to us so that it makes sense. And this is why we do the doctor shopping, right? This is why menopause is a specialty. This is why it's important to hook up with someone who really knows what he or she is talking about, to go, as you say, yes, deep into the weeds or quicksand, and help you. It is possible. It is doable. Please do it. Please, please, please.
Carolyn, from your mouth to God's ears, right? As my grandmother used to say.
My lips. God's ears.
Ordinarily, a young woman who's having menstrual disturbances would be able to reach out to someone who is expert at female hormones.
Right. And
oh my goodness, gynecologists in my lifetime as a physician have helped my patients so much. Oh my God, I'm so grateful to obstetricians and gynecologists.
Oh, yeah.
There's very few of them. They went into gynecology a lot because they love surgery. They're really great with their hands and they love it. And they're great at procedures. But there's very few of them that are great at hormones. And because of the Women's Health Initiative, what should have developed as a specialty in hormones, in treating women in menopause, never developed. So when you say doctor shopping, this is your principal job, as you pointed out, Carolyn, that if you're a young woman and you're suspecting your hormones are imbalanced, you just can't go down to your local doctor and necessarily find an expert in hormones. You have to go shopping for them. You can contact us at the Menopause Method or just read our book and that'll give you an idea what you're looking for. And then talk to the office managers, interview them. It's shopping. It's like shopping for anything else. That's one of your main jobs. It's when you have suspected hormonal disorders, as Carolyn just so clearly said, you need to go doctor shopping.
I learned that from someone I know well. And one thing that is really pretty exciting to me in, not literally working, like getting paid for working, but working with the women that I do. And the years go by, and guess what? They've done the doctor shopping and they're feeling better. And they've ended up at a certain place with certain doctors doing certain oils, and they're enjoying it, and they have done their due diligence. You talk with someone brand spanking new, many blessings to the kind patience that is given, because many of us are absolutely clueless, and then we get a clue. So you can see the questions better than I am. Thank you, Kathy. Yes, learning a lot this morning. You're welcome to your thank you. You could see the questions, Dr. Rosensweet, because I don't have the cursor, and I apologize. But there are a lot of questions up here. And do you see anything that can you be more specific in regards to, I'm not sure. Try.
Well, here's one. I'm not sure if you will get time to answer this. I'm 56. I take DHEA daily, 20 milligrams of progesterone caps nightly. And I think there's more to the question that I can't see. I'm so sorry.
Yeah, exactly.
I want you why I chose this one is if you're taking DHEA and you're taking it orally, we want to be sure that you're taking 15 milligrams or less. And whether 20 milligrams of progesterone is sufficient nightly, that's an issue. I mean, in my practice, the most common dosages that women arrive at on oral progesterone is somewhere between 50 and 75 milligrams. Some women take 100, some women take 125 milligrams. If you read our book, we sort of give you guidelines as to how you determine a progesterone dose. So what this is making me wonder, JJ, is what's the level of expertise that these subjects are being dealt with you? And so it's back to doctor shopping, or I need more details. And then I'm assuming this word BIERS refers to biased. But just for everyone, DHEA is very important. You're all going to be depleted in it. And be sure you're taking 15 milligrams or less. Most women come in somewhere between 7.5 and 15 milligrams when we really examine the ultimate 24-hour urine hormone test on them.
Which again, yes, is another thing, the 24-hour urine hormone test. Absolutely 100%. One woman is saying, where's my libido? Help. I mean, a lot of women say that, don't they?
Yeah, how important it is. And we tend to think again, there would be more information that we would need to be able to address anyone's specific libido needs. But libido has a big, major hormonal component to it. It's not the only moving part in libido, my God. But when we think of libido in a woman, we think primarily of testosterone, inadequate testosterone levels. And for sure, your testosterone is declining just like all the rest of the hormones are. But it's not the only one. Estrogen plays into libido. Progesterone plays into libido. I had a woman patient once that her libido was pretty much dependent on progesterone. And not only that, it was a very narrow pharmacological window. If she took too much progesterone, she would lose her libido. If she took too little progesterone, she would lose her libido. They all play in, and part of really individualizing hormone treatment for any woman in perimenopause or in menopause is to watch that libido, because that's so important to so many women. And we really work hard to get the hormonal balance aspect of it correct. And we want to get the testosterone right. We want to get the DHEA right. We want to get the estrogen right. We want to get the progesterone right and optimized for that woman. And if we're getting them optimized, a lot of women will have return of libido. Now, oh my God, libido relates to a lot of emotional and connection and relationship issues. So I'm not going to go there today. But you can have anywhere from zero libido. You can have wonderful hormones and zero libido. So I'm not going to go down that path today.
Right. We don't need to. Yeah. Okay. Oh, JJ came back, and I'm sorry to interrupt you, but she says, sorry, I'm 25 DHEA, 5 to 10 testosterone, 200 progesterone, bias, no libido or any sensation or feeling in my erogenous zones. My doctor says that it's not hormone related. I don't sleep well, and I suffer from mood and depression. How often do we hear this, Dr. Russell?
Well, to the extent that 25 milligrams is, from my opinion, is an excessive amount of DHEA to be taking. And when you're saying you're taking 5 to 10 milligrams of testosterone, I'm assuming that's what you mean. The clues here is that you're not doing this in conjunction with an expert, because an expert in hormones is not going to give a woman 25 milligrams of DHEA. And at high likelihood, if you were to do a 24-hour urine hormone test, you would see some imbalances within those hormones. So again, it takes us down to the primary job of every woman in menopause that I see, as Carolyn was saying earlier on. It's find someone who's an expert at it. And together as a team, you guide that process to see what your individual hormonal needs are and balances are, and they're ultimately confirmed by 24-hour urine hormone tests.
Optimal words. Together we can, as a team. Oh, is that important? There's a question that I have that I get asked a lot. I have asked it of you, but I'm going to ask it again because I think that right now is the appropriate time too. Women will write to me and they will say, and I've asked you this many times, or did back in the day, what is an optimal operative word dose of estrogen? I am unable to give a number.
Well, the numbers are known, and we actually, for 24-hour urine hormone testing levels. And the optimal amount is somewhere between sufficient estrogen to protect the vagina or restore vaginal health and to protect the bones. On a 24-hour urine, that's about at least 8 micrograms, for what this is worth, total of estradiol and estrone, total potent estrogens. So we know what that bottom line is. You
right.
At least want enough estrogen to keep vaginal health reasonable. And if you do, if, for example, you do not need lubricant on intercourse, if you're having intercourse, you are most likely have sufficient vaginal health. And in order to do that, we know how much estrogen you need on a 24-hour urine hormone test. Now, at the upper limit, what's too much? Well, in my opinion, it's too much if you're overstimulating breast glandular tissue and producing breast tenderness. We are a no breast tenderness method. When someone has breast tenderness, that's overstimulation of breast glandular tissue, and we effort and we do what we need to do until that breast tenderness disappears. And that breast tenderness can show up on a mammogram as increased breast density. That's a risk factor. We do not accept that. It could show up on a information. So we know what the lower and upper limit of normal is for the potent estrogens on a 24-hour urine hormone test. and that happens to be, just as far as numbers goes, between 8 and 24. 8 and 14 micrograms per 24 hours. So we know what that is. Now, there are exceptions. There are some women that they're losing cognitive function, and that is so crucial. And so many women who are losing cognitive function will have it restored by that reference range of 8 to 14. Enough estrogen to protect the vagina and the bones, well, not too much to cause excessive breast glandular cell proliferation, any breast glandular cell proliferation. However, there is a certain number of women that they need a lot more estrogen.
So you never say never.
So you never say never. So I was on a panel with a 65-year-old physician who told me that at the age of 55, she started to lose the ability to think clearly. And it got so severe that she was thinking she's going to have to quit medical practice because she cannot keep her mind together enough. Mm-hmm. And not only that, she was looking down the barrel of her mother and her mother's sister, that woman's aunt, both having developed dementia. Well, she knew, this physician knew the relationship of estrogen to cognitive function, and she kept on jacking up the dose of estrogen, and she cleared up. And it's a miracle when that happens.
It's amazing.
And she had to take dosages so high that her period restored. And that's going to take many women beyond what I said the upper limit of normal was earlier. It could lead them to breast glandular cell proliferation because the dosages are so robust. They turn out to be 3 to 8 times the amount that a younger woman would have.
Risk benefit?
Yes, exactly. Because and we can always monitor the risk. We can always do mammograms and thermograms and do other issues that can help breast health. But this woman, she needed, as many women do, rich, robust levels of estrogen to think clearly. So you do what you need to do, because all you have to do is lose some of your cognitive ability, and you know how important that is. So although the reference ranges usually stop at the upper limit, they fall shy of useful levels, actually. They're right there at the border of useful levels. They're at here's youthful levels. See, I'll try and do a better depiction.
I know, it's weird.
Here's the range of estrogens needed for a young woman to menstruate and prepare for lactation. And there's some women don't need as much, some need a lot more, but there's a reference range there. It's not a specific one number, it's a range. Well, for the highest percentage of women in menopause, they don't need this much. In fact, they do great. They get vaginal health, they get cognitive function, they get bone health, they get arterial protection right below that youthful level. However, you never say never. Some women in menopause, we got to go higher than that usual menopause range. We got to get those into youthful levels and even beyond to get restoration of clear brain function.
Back to the teamwork. Back to the teamwork.
Yeah.
Back to the doing the doctor shopping, finding that
someone really expert to help guide you into.
You have to have someone really expert, because this isn't heady. This is not like take 2 pills and call me in the morning kind of thing. You know what I mean? It's a journey, and it takes patience, and it takes me back to that time that I had my major meltdown. Thank you very much. I thought I would, just take a little bit of hormones and go on my merry way. And I found differently. It took me a couple weeks. I'm just kidding. It was a good journey once I understood, and I was not frightened anymore. And I was dealing with experts. We have a lot of questions here, and we are at 10 minutes to 7. What I would like to ask you, Dr. Rosensweet, if we could, is if you will certainly screenshot these to me, because then I can get to them and, answer them. I want to just let people know that we will not be interviewing on Thursday, and we will not be interviewing next Tuesday. We'll have a small hiatus. I'm going away to a retreat.
The show will go on. Actually, I've collected questions, and I'll be answering questions and talking about topics this Thursday and next Tuesday. And we may even have a surprise guest on next Tuesday. And then Carolyn comes back a week from Thursday. But Tuesday and Thursday and Tuesday will continue.
I stand corrected, and I apologize.
I forgot to tell you. I just talked about it earlier.
The show must go on, with or without me. Oh, I've had a hysterectomy. Do I still need progesterone?
Absolutely. 100%. Now, that's not what the common conception is out there. It just speaks to anyone who holds that opinion that you don't need progesterone just hasn't taken on hormones as a specialty, because all of the any hormone that you can name has multiple effects all over the body. There's cell receptor sites in almost every single cell in the body, including for progesterone. And the reason that there's a conception out there that if you don't have a uterus, you don't need progesterone is that one of many of the functions of progesterone is to balance the estrogen so there's not an excessive thickness to the endometrial lining and you don't bleed postmenopausally. Very important function of progesterone. But progesterone has so many other effects. Progesterone has such a major effect in the brain, i.e. your mood. And progesterone has such a major influence on your ability to sleep. And progesterone is the only chemical that I know, biochemical that I know, that promotes the deposition of bone from bone-producing cells called osteoblasts.
Yes, osteoblasts. Our friends.
So, in my non-humble opinion, every single woman in menopause needs progesterone for her whole life. And it's wonderful. It's a wonderful hormone.
It is. My face is doing that because it's so oftentimes said, oh, you've had a hysterectomy. You absolutely do not need progesterone. Don't take it. Yeah.
That has been the common misconception for decades and decades and decades. But things are changing, you know.
Yes, they are.
People will get it about progesterone.
They are beginning to get it. The two books, Happy Healthy Hormones, which on the ins and outs of menopause page with David Rosensweet, MD, this wonderful man right here, can be downloaded free. And the other book we make mention of often is Estrogen Matters by Dr. Avram Blooming and Dr. Carol Tavris. And between those two books, we read them, we learn, we educate, the less we fear, and then the more empowered it is we become to learn how to help ourselves. And then we hope to help our doctors then, who are
I'm going to interrupt you for a minute. Dr. Blooming's book, Estrogen Matters, is a phenomenal contribution because it offsets the fear that was wrong
and
about women taking hormones. It was false.
Yes.
And the doctors Blooming and Tavris have just been so rigorous with over 450 references to the medical literature, pointing out which the original Women's Health Initiative Committee ultimately recanted in 2017, that women who are on hormones are at less risk for breast cancer, heart attack, and stroke than women who are not treated with hormones. Now, we're all at risk for cancer. As a male, I'm at increased risk for prostate cancer for reasons. As a woman, women have increased risk for breast cancer. There are reasons for that. And at the same time, a woman treated with hormones is at less risk for breast cancer, heart attack, and stroke than a woman who goes untreated. That's the main contribution of Dr. Blooming's book and Dr. Tavras's book. They're major proponents of what to me is not the optimal estrogen and progestin that women should be taking. They're talking about oral Premarin and Prempro, oral estrogens and progestins. No. If it was the only thing that we had available to us on the planet Earth, fine. But we don't. We have these elegant compounded bioidentical hormones, which are so much in advance to me, and the ability to precisely balance and replenish women's hormones and in the proper way. So yeah, read Dr. Blooming and Dr. Tavras's book. If you have any doubts about, you're concerned about risk, they really clarify this beautifully. It's an amazing job. But
well, I mean, isn't it something you get asked almost every time, or the elephant in the room? You know, breast cancer.
Yeah. So that needs to be rectified, because women need hormones. Men need hormones. Men undergo hormone depletion as well. And this is not just a female phenomena. And women undergo hormone depletion. And yes, you need hormones for your whole life, in my humble opinion.
In your humble opinion,
even women who've had breast cancer and have that breast cancer properly treated are at less risk for recurrence of that breast cancer if they're treated with hormones than if they receive no hormonal treatment at all, or these estrogen blockers. So this is very, very important that you know this, because I saw a question flash by, and I'll try and answer it on Thursday, about a woman who's having a horrible experience after having breast cancer and breast cancer treated. So for that woman who asked that question about hormones, please go out and purchase the book Estrogen Matters by Avram Blooming and Carol Tavras, and read that book. That is your homework. And for any of you out there that have concern that you'd be at risk if you want to take hormones and you know you need them, but you're concerned that you're going to be at risk for breast cancer, heart attack, or stroke if you take it, buy that book, Estrogen Matters by Carol Tavras and Avram Blooming. We are not recommending the hormones that they're recommending, but they've done a great service to totally offset and reverse that fear that was wrong about increased risk. And I've had personal discussions with Dr. Blooming. I was introduced to Dr. Blooming by Carolyn
Shapiro.
Carolyn Shapiro. And what a privilege that's been. And we
It
had
was my privilege
discussions about the actual hormones that are being used, but their contribution is around offsetting that misinformation about increased risk, which has done so much harm on this planet.
So, just saying to say, I did have breast cancer twice, double mastectomy, chemo, radiation, the all nine. I had lunch with Dr. Blooming. Come to find that, well, let's just say it was an interesting lunch. It was fabulous. My cancer number, anything under 38 is good. My cancer numbers, much to the dismay of my primary physician, went down. They all went down from 11 to 9 and from 9 to 2. And he was like, what? You know, I mean, and he knew that I've done my due diligence in regards to menopause and treatment. And he was terrified to treat me. He was, the doctor. Again, risk benefit for me.
Well, let's go down that path a little bit. Unfortunately, at this time in history, a lot of physicians are still living off of misinformation because it has not become popularized. Even the original Women's Health Initiative study group who published the misinformation because they did not have evidence, they did not have statistically significant evidence that there was an increased risk, but they published it anyway, and the press got a hold of it and made it seem like there was increased risk. There was not. That original study committee published in the original Journal of the American Medical Association 18 years later, and the statement they made was, the original study committee of WHI is that after 18 years of follow-up, there is no increased risk for breast cancer, heart attack, and stroke for women being treated with hormones. So this is very crucial. And, bless all the physicians out there who got frightened and concerned that they would be doing harm.
Well, right, because they care.
And the information has not been public enough and publicized enough that actually women are at less risk. But there's a lot of forces out there trying to get that information public. And my goodness gracious, our time is up. And Carolyn's going on a well-deserved holiday?
I am in the School of Applied Functional Medicine at 63. Thank you very much. Yeah, and it's hard, and it's Eddie. I will be going to Austin, Texas for a retreat, seminar, conference, sort of relaxing time.
So it's an educational adventure.
It is, and I have to fly, so that means I have to hold the airplane up, and that is not easy to do. And nobody says thank you when we land. It's a hard job. People are ungrateful, but whatever. They're people. It's all good. I loved our hour today, Dr. Rosensweet. Love to the women. Thank you so much. I'll get screenshots. Dr. R's got the show. He knows how to do this without me. Go figure. So I want to wish everybody an amazing, 10 days or whatever. Have fun. I am going to be without a computer, which is kind of cuckoo crazy. Don't really know how to use my cell phone, so that's a wrap. I'm going to be outro. Everybody enjoy Dr. Rosensweet. Many blessings to you and your kind patience and your kind ways and your amazing intelligence. So appreciated. And I guess that's it.
Until next time.
Until next time, I'll talk to you in a week. And women, enjoy your day. Use your voice. We will talk later. Bye.